Okay, so I'm going to do the neck, vessel, and heart assessment. Hey, I'm Jennifer Smith. I'm here to do your neck and heart assessment. What's your name and date of birth?
John Doe, January 1st, 1902.
Okay. I'm going to wash my hands.
Thanks.
Mhm.
Appreciate that.
Don't be silly. Okay, we're going to be inspecting the jugular venous pulse first from the right side of the patient at a 30 to 45 degree angle. And can you turn your head slightly to the left? Okay. And if you need to, you can use a light. And you're going to be looking at it here. Okay, it may not be visible until you lower the bed more, and it should not be visible over 45 degrees. Next, we're going to inspect, auscultate, and palpate bilateral carotid arteries individually. They are located in the groove between the trachea, and to the right and left are the sternomastoid muscle. Okay, turn your head for me again. Okay, so here's the sternomastoid muscle, and we're going inspecting, and the carotid artery pulse is I can't think of the right word, but it's just a beat, a pulse. But the jugular vein is an undulating that we just looked at, and it's kind of 2 pulses, 2 out and 2 in. So you can distinguish the difference there. And if you were to occlude or apply pressure to the jugular vein, you won't feel it. But when you apply pressure to palpate the carotid artery with the pads of your fingers, you can feel it. Okay, turn to the other side for me. Okay. Then we're going to auscultate.
You're gonna what?
Okay. I need you to take a deep breath and hold it with the diaphragm of your stethoscope. Okay, breathe. You should not hear any blowing or any sounds. Okay, turn to the right a little bit. Take a deep breath and hold it. Okay, breathe. There should be no blowing, swishing, or other sounds heard. The pulses were equal at 2+ with no variation in strength, and the contour was smooth and rapid on the upstroke and slower and less abrupt on the downstroke. The arteries were elastic with no thrills felt. So we will move on to the heart assessment. So inspecting for visible pulsations with the head of the bed, 30 to 45 degrees. Again, you'll inspect from the patient's right side and look for the apical impulse in this area. And it may or may not be visible. If it is visible, should be about 1 to 2 centimeters. And it should be at the left mid-clavicular line at the 4th intercostal space or the 5th intercostal space. There's no heaves or lifts noted. Okay, we're going to palpate for the apical pulse for the location, size, and strengths. Again, with the head of the bed around 30 degrees. It'll be at the 4th or 5th, bless you, mid-clavicular line. You should count an apical pulse for 1 minute, and we will do that as we're auscultating. In obese patients or women with large amounts of breast tissue, the apical pulse may not be palpable. And then you will palpate for abnormal pulsations or vibrations at the apex, the left sternal border, and the base. So the apex is the top or superior, the sternal border, and the base. No abnormal pulsations, thrills, or vibrations noted. And they're going to auscultate for heart sounds, for rate and rhythm. We'll place the diaphragm at the apex and listen closely for the rate and rhythm of the apical pulse for 1 minute. It's not fast. Okay, so I'm faking it with my Apple Watch, so we're going to do it because he wants to know. .86 and regular.
Is that different than your heart rate?
No, that's your heart rate. Auscultate S1 and S2 heart sounds for sound location. And starting here, I'm going to auscultate from the aortic and pulmonic, the apex, down to the base with the diaphragm, and then I'll turn around and go back from the apex up, listening with the bell for murmurs, and then we'll come back and tell the findings. Okay, the aortic is the second intercostal space at the sternal border. So you can feel 1, 2. And pulmonic is the second intercostal space, the left sternal border. And then right under that is Erb's point. And at Erb's point, you can hear S1 and S2, the lub and the dub. And then mitral valve, tricuspid valve. And you hear S2. And then over to the midclavicular line, the 4th or 5th intercostal space is the mitral. And then you switch your stethoscope, and this is what you can usually detect murmurs better with the bell. Coming back to tricuspid. Herb's point. Pulmonic. And aortic. Okay. So you can, when you're listening for S1, you also look at the carotid pulsation, and it corresponds and is loudest at the apex of the heart. S2 immediately follows after S1 and is loudest at the base of the heart at the tricuspid and mitral. There were no extra heart sounds heard and no murmurs heard.